For years, the idea of occupational therapy in primary care has felt like a professional aspiration, a quote unquote gold standard that we discussed in the classrooms but rarely saw in actual job postings. Today, that reality is shifting. In Norway and Sweden, there have been new statutory mandates that have solidified OT as a primary care service. Here in the United States, we are moving past the era of, at best, co-location in primary care toward true interprofessional integration, driven by the rise of alternative payment models and the 2026 Medicare updates to advanced primary care management. We are finally getting our foot in the door to be recognized as an essential team member in chronic disease management, mental health, and aging in place. During today's episode, we sit down with Dr. Ashley Hall, a leading voice in this movement, to discuss how clinicians can finally step out of the hypothetical and onto the primary care team. So let's dive in. Welcome to the OT Potential Podcast. I'm your host, Sarah Lyon, OTRL, and I wanted to let you know that this podcast may qualify as continuing education for you. You are probably listening to this podcast on a free podcast platform, but to gain CEU credit, you will need to be a member of the OT Potential Club, our OT continuing education platform. You can go to otpotential.com to learn more. Okay, here we go. As I mentioned at the top, joining us today is Ashley Hall, OTD, OTRL, CAPS, LRC. Ashley graduated from USC with a bachelor's degree in health promotion and disease prevention and a minor in occupational science. She continued at USC to pursue her master's degree in occupational therapy and then her doctorate of occupational therapy. Her doctoral work focused on interprofessional primary health care. Dr. Hall previously served as the coordinator of primary care residency and services at USC Chan. For over a decade, she provided patient care and trained occupational therapy and other health professional students in primary care settings throughout the LA and Orange County areas. She also worked for 8 years as a lead occupational therapist on the USC Geriatric Assessment Program at Keck Hospital, providing care in the home and the clinic for older adults and their families. Dr. Hall now enjoys teaching students and is passionate about student learning to support the next generation of occupational therapists who will help people live their lives to the fullest. Dr. Hall is trained in cognitive behavioral therapy for insomnia and is a certified aging in place specialist. She also served on numerous volunteer leadership and national subcommittees, such as the National Quality Forum Technical Expert Panel on Preventative Care. So without further ado, I will patch Ashley into our live studio. Welcome to OT Potential, Ashley. It's so great to have you.
Hi, thanks. I'm so happy to be here. Thanks for inviting me.
I am so thankful that I found you at OT Potential. We've been talking about just this new era of healthcare that we are entering into that will be so focused on chronic disease management. It will be so focused on aging in place, which means that we as therapists need to be more focused on prevention, on conservative treatment, on getting to things earlier. And that means, hypothetically, that we need to have a stronger presence on the primary care team. The way we've talked about it in the past is this primary care triad, where it's the medical team, who we think of traditionally in primary care, behavioral health, who has made a ton of strides in embedding themselves in primary care, and then us as OTPT SLP also really owning our place as that like functional leg of this three-part stool. So I've spent multiple episodes talking about this the whole time and really advocating for how important this is. But honestly, I, in the United States, did not know any OTs that work fully in primary care. So when I heard about you and your background, I was so excited just for this, to meet you and for this conversation. We have so many details to talk about today, but I just want to start farther back in your story and hear how you got interested in OT and primary care. That was not on my radar 10 years ago or 3 years ago even. What was that early interest like for you?
Yeah, and I'll be honest, it really wasn't for me at the time either when I was starting out. I people ask me like, "How did, you seek it out?" And I was like, "I didn't. It kind of found me, honestly. I more fell into it." And that's more because it really, thinking about how small primary care might feel or OT's role in in primary care might feel right now compared to where it was, in 2011 when I was getting started with this work, it was even less, right? It really wasn't something that people were talking about at the time. So at that time, I was in 2011, I was a level two fieldwork student at our faculty practice at USC. And I was very interested in health and wellness and prevention types of things. And it just so happened that around that time, we had started a relationship with a safety net primary care clinic in the downtown Los Angeles area. And so part of what I ended up doing during my fieldwork and then into my postdoctoral residency was to go there and start working there and like exploring that relationship with that safety net primary care clinic. So that's where I started. And then I loved the work that I was doing, working with in that context, all of the different diagnoses and people I was seeing, the emphasis on working with the community and being of service to the community. And so I was there for my full post professional doctoral residency. And then eventually I was hired. I was hired by the University of Southern California to expand OT services into primary care and to continue on some of that work. So that's how I got started.
My mind is already blown. I'm like 15 years ago, you were pioneering this work. I agree. I don't think that many people were talking about it and what a unique opportunity to see OT in this unique setting. I would just love to hear more about what the work actually entailed. I know you've done OT and primary care like in a couple different ways in a couple different
Yeah.
settings. But yeah, tell me about the work and what it entailed. There's so many details I would love to hear more about.
Yeah, absolutely. I mean, I think the bio that you used to introduce the episode actually covered a lot of that. But just to back up a little bit, so starting with the safety net clinic that I worked in downtown Los Angeles. So working mostly with low income, uninsured or underinsured individuals. And that was in the downtown Los Angeles area. And then when I was hired on working in primary care, so I was working in various clinic primary care settings, mostly with family medicine providers, but also internal medicine and doing things like rounding with them, starting patient care, providing brief interventions with their clients. We came up with and piloted lots of different models. Sometimes I would go in first, sometimes they would go in first, sometimes we would go in together. And we can talk about some of the models a little bit later, but exploring a lot of those things and finding what would fit for different providers and different contexts and the different sites that I was going to. And then I eventually shifted into clinical leadership, so becoming the coordinator of our primary care residency and services at USC Chan as our service lines continue to increase in primary care. So I was in that role working with OTs at multiple sites in the LA and Orange County areas, and then began to work in other areas beyond patient care as we continue to grow. So I then became responsible for things like onboarding new family medicine providers, meeting with new sites and advocating for OT at those sites, training residents at other locations like Kaiser Permanente and places like that. And now I'm the associate program director of our entry level doctoral program. And so I often teach our primary care course and still working with primary care providers, but now more in of a teaching context. So I think, did I get to everything?
Yes, I would love to hear just a little bit more about the relationship with the providers. Like,
Yeah.
I worked in a small hospital here in Nebraska, and I had such a great relationship with the providers, but it was still pretty siloed. And I
Sure.
always wish that I could just like have more touch points with them, just that we could function more as a team. Did you get to
Yeah.
experience that, or were you still siloed? Like, what was the team relationship
Such a
like?
good question. And I mean, honestly, it really depended because I did work in so many different models and so many different contexts. Sometimes, yes, it honestly was a little bit more siloed, right? Like I would work with one provider and they would go in and they would come back and kind of be like, oh, like this patient would like to see you. And it would be good. We would still like go back and forth, but it didn't feel as integrated versus like when I was on our geriatric assessment team it was, I would say, a very high functioning team, right? Like I'm on this team, and at the time, I had maybe like 5-ish years of experience as a clinician, but I'm on this team with people who have like 20, 25 years in their respective fields. And so I actually received excellent mentorship through that program, but I would say that was also a more highly integrated team as well. And so I obviously agree. I have a strong preference for like when we can be more highly integrated onto those teams. And it really does feel like it goes beyond co-location and into that higher level of integration. That's always when I think we're meeting the needs of our clients the absolute best,
Mhm.
right? So that was always my preference, but I kind of saw it all, to be
Oh,
honest. Yeah.
and on these teams, sorry, I'm so curious about the structure of the
Of
team as I'm
course.
thinking about it. Ideally, there's or we would just all probably love to be in a close relationship with providers. And then were
Yeah.
there other ancillary team members that you got to work closely with, like behavioral health or someone looking at social determinants of health? What were those other ancillary roles, and were there times when it felt really integrated and cohesive?
Yeah, I think it depends on which model we're talking about or like which context or sites we're talking about, just because I have been involved in so many over the years. I think even starting from the very beginning, like needing to think about who's scheduling the patients, right? Who is onboarding them? Who is greeting them at the front desk? Who's your back desk staff? I think those were really important relationships that I work to foster with over the years is, yes, there is the physician, but also be aware that like the team goes much larger than that.
Mhm.
And so even thinking about what are all of the people that I need to work with along the way, so I really appreciate the opportunity to think about like the full scope of the team, right? And some of those are people who, like I said, are the schedulers and things like that, your coders, your billers, right? But then also thinking about the team, like you were saying, in terms of behavioral health, right? So, of course, working with other people on the team that are not, your MDs, your DOs, your PAs, your NPs, but also working with social work, psychology. I had dentistry colleagues in our primary care clinics as well
Mm.
over the years. Of course, in addition to OT, physical therapy. So just a whole host of various people who would come up. And then honestly, one of our biggest advocates, I would say, on our healthcare teams would be the medical assistants. So I know that a lot of the MAs saw the benefit that OT had for the clients and really advocated to management in support of like, we need OTs at the site. So always want to acknowledge that our medical assistants have been a wonderful team member as well and very important to the flow of clinics and making sure that patients' needs are getting met as well. So I see lots of people as a part of that team. Absolutely.
Hmm. As you were saying that, I'm already like, "Oh, yes, this is the setting so many of us want to work on because we want to work in these highly integrated teams," and it's kind of baffling, that these jobs are hard to find, currently in the United States. So where I wanna take us next is actually looking outside of the United States because, I think that or in my understanding, there are countries where OT in primary care is actually more advanced than we are here in the United States, where OT is more of an embedded part of the primary care team. Can you tell me about your knowledge about what this is looking like globally and maybe some countries where this is just like up and running more than it is here in the United States?
Yeah, absolutely. And I think to also like zoom out a little bit for a moment, really important to distinguish between primary care and primary healthcare, which I think we've alluded to a little bit in the conversation so far. But just to spend a moment on this, because in the US, and I think in a lot of like Western countries where we have a lot of emphasis on a medical model, we use the term primary care and sometimes interchangeably with the term primary healthcare. But primary care, like I said, it's more westernized. It's more emphasis on traditional medical model. It's doctors, it's PAs, and it's nurses who are providing care to patients. It's very limited in its scope. Now, primary healthcare, on the other hand, which, fun fact, was established in the Alma Ata conference in Kazakhstan in 1978. So it has origins, though I would say even beyond that of like people doing work in primary care well predate that timeline. But this is really the term that was created around this idea of health for all, right? Meeting the needs of communities, right? Meeting them to the fullest extent of what they mean, right? Beyond the medical model. And so, we hear that term sometimes in the United States, but like I said, it's really, you'll definitely hear it more when we think about things like people who are working in the global south, First Nations individuals, indigenous communities and populations. And then anytime we're looking at models where we're looking for like broader community centered decolonizing approaches to health. So I think with that in mind, absolutely, like you will see in a lot of countries where OT is much more involved in especially primary health care. And there's a longer history with that than we perhaps have here in the United States, or OTs are more involved in that. So just going to your question about like other countries, and this is by no means an exhaustive list, but for example, in Ireland, in the UK, they have the wonderful Optimal program, which stands for Occupational Therapy Led Self-Management Support Program. And it's for people who have multimorbidities. They found it to be cost effective. So really wonderful role that OT has demonstrated here in primary care. In India, there was, I think in October of 2025, a really nice advocacy win where now OTs in India, their competency-based curriculum for OT was established to where they're now the first point of contact or designated as first point of contact professionals and are seen as primary care providers. So that's really exciting. Canada, I see a lot of publications around like chronic disease management. There was a study done about OT addressing chronic pain in family medicine groups in Quebec, I think is where it was located. That just recently came out maybe a year or so ago. In Sweden, we see the Be Well program and OTs using telehealth to address needs in primary care there, addressing stress related illnesses. And then I would have to also, for shame, I would absolutely have to mention that just at our last WFOT Congress in Bangkok, Thailand, Dr. Chinchai gave a plenary keynote addressing OT using primary healthcare as the principle to enhance accessibility of OT services for people living with disabilities in their homes and communities, and also partnering with what they called village health volunteers as part of this service delivery. And then also a lot in South Africa as well, using a community oriented primary care approach, which dates well back to, a while ago. And then, we saw presentations too at WFOT from people in South Africa about many different, the models that they're using to, again, explore OT's role. So I think we have lots of models that we can look at globally, lots of OTs doing excellent work in primary care and primary healthcare contexts. I agree. I think in the US, we are a bit limited, but I still like to look at, and I hope other people enjoy looking at these models and can still learn and take a lot away from them so that instead of feeling discouraged about like, oh, we don't have access to these things in the US or we have different restrictions that feel very limiting, to think, well, but maybe there are opportunities to go beyond this, right? Other countries are demonstrating some really nice progress here. And can we see about how to incorporate some of those elements into our own work as we continue to advocate for OT's role in primary care and primary health care in the United States?
And thank goodness these movements are happening around the world. And thank you to the people researching them, because then for
100%.
us here, where we are just earlier in the battle, that like gives us so much to work with to be able to just show how this is helping in other countries and the multiple ways we can help. Like that was what was standing out to me as you were saying the different ways that OTs can be involved. It's not like it felt like each country kind of had a slightly different approach, and OTs had a slightly different focus. So it really opens your eyes to whatever the need is.
Yeah.
There
And
is a
that
way you can adapt to that and meet that specific need in that specific place.
Yeah, I think that's exactly what it is, right? And we would even see, and maybe we'll talk about this in a moment, but like OT in primary care in the United States, it's so hard to talk about like what is it because everybody like the context is different, right? And so there's so many different places where people are doing work in primary care and primary health care that work can look so different. So of course when you go even beyond that to a global level, then you're going to see very different models. And so lots of different OTs doing amazing work in this area, in a wide variety of ranges, and how it is and it must be responsive to serving the needs of the population and other communities, right? And so, of course, that is always going to look very different.
I want to press a little bit on that and dig into it a little bit because, or I want to know just how you see the state of primary care here in the United, or OT and primary care here in the United States. Like if I were to summarize it, I would be like, it's something that we talk about a lot, and it's something that we desperately need because of our higher cost, worse outcomes scenario. But I only know Ashley doing it. What am I missing in that description of it here?
Yeah, I mean, you're missing the and all of these other OTs, right? Who are in the United States and who are doing the great work in primary care and in primary healthcare, right? Um, I think there was a lot of buzz around this, like we said, maybe 15, 10, 15 years ago when we were really pushing forward, seeing opportunities to get more involved with OT and primary care and primary healthcare. I think that took a little bit of a dip, not in terms of the work that's being done, but maybe just in terms of like the public attention or like even in our profession, the attention on this work. But I think it has been continuing to grow, maybe a little bit quietly or maybe a little bit less or a little bit more under the radar. But nevertheless, like OTs are out there and they're doing this work, and I'm seeing excellent like expansion into many different areas. I have a number of colleagues where it's like it's now no longer just them, but it's them and their past students or now new faculty are coming on, and these relationships and networks are being formed. I was looking at because AOTA Inspire is coming up this week. And so I did only see a handful of presentations on OT in primary care, but I think also looking at if you looked at the program for WFOT, a lot more on OT in primary care and primary health care, many countries, but also from the United States. So I know there are wonderful OTs out there who are doing that work. And then also the publications that you see coming out too, right? So OTs publishing their work, publishing, what they're billing for and how they're able to bill and be reimbursed for the services that they're providing in primary care and primary healthcare contexts. And that's something that we didn't have when I was getting started in 2011. And we were trying to figure out how do we bill for these services and can we get paid for them? And we can. And it's really wonderful to see not only do we know that we can, but now people are publishing and disseminating that work. So kudos to all of the amazing OTs out there who are doing that work, who are publishing that work and getting the word out about that.
I love the opportunity to zoom out and think about what is happening around the globe on this. There is a lot happening in the United States. But I now want to like zoom in and look at what does it look like to bill? What do our assessments look like? What do treatments look like? To just give people a really practical understanding of this. I think it can feel really ethereal. But let's start with the very important but least fun part, the like billing models that exist here in the United States?
Yes. Billing is always, I think, a great question. And I'm not going to lie, it's a tough one to answer. We're going to talk about why, because there are a few reasons. I'm not attempting to be deliberately evasive by any means. It's just so big and there are so many different models and the context that you're practicing in matters. So we'll talk a little bit about it, but it will be something that like people will sort of need to do their homework a little bit and be like, okay, what is the setting that I'm practicing in? How does billing even happen and where does OT fit in? That's really what it boils down to. I think billing's a really great question though, because one of my key sticking points, or sticking points isn't the right word, but one of the things that I would really emphasize to people is that you need to, when you're thinking about getting involved as an OT and working in primary care, primary healthcare, is to make sure that you're thinking long term with your vision, thinking about sustainability of this work. And in order for this to be sustainable, it has to be paid for, right? So I think we need to be talking about this. People are talking about this. So let's talk about it here because it is one of the key determining points, right? Is like this all sounds well and good, but how do I actually get paid for these services? How do I make sure that this is something that is sustainable for the long term? And I had a geriatric colleague, a geriatrician colleague, who I've worked with for many, many years. And she always talks about this idea that healthcare, she doesn't like to call it a system anymore. She likes to call it a business. And it's this idea that I think if you are going to be doing this work in primary care in the United States, you do need a little bit of a business mindset to do this work. And so you need to think about billing and reimbursement and coding or whatever it might concern you with. So, first off, think about where are you working? What kind of place is this? How does the billing work here for other providers? If there aren't any other therapy providers, like what other providers are here and how does the billing work and try to understand it? Is it as simple as, and this is often where I was working, can you bill for CPT codes, right? Traditional OT codes that we would bill or think of as like traditional OT codes for billing. Or are you in a place though where the payment structure has shifted to more alternative payment models, right? Things like a federally qualified health center where you are shifting away from utilization based reimbursement processes and you're now looking at what's called a per member per month reimbursement. And so maybe you're not billing directly for OT services, but you're able to advocate for inclusion of occupational therapy services into that per member per month, that PMPM model. And so that will increase their PMPM model and your salary will be covered by that, which is actually something that we had previously been able to advocate for at a federally qualified health center. So it's going to require a slightly different way of thinking, right? Again, just to give a couple of examples, but there's lots of different places where primary care is happening. There are lots of different ways that primary care is being paid for. And so, of course, there are lots of different ways that you can think about billing for OT services or somehow capturing or the reimbursement of occupational therapy. So does that make sense? It's it's a big one. It's an important one, but it's a big one.
Yeah, and I think it's hard to overstate how much it seems like our payment models are shifting. Like there's just so many new
Absolutely.
programs out there. We've talked value-based care on the podcast multiple times too. And the idea of just entities we don't like ACOs taking on contracts where they are taking more risk and they're more incentivized to provide like effective low-cost care. Like if
Yep.
we start to understand what's happening in our local area, the different models that people are participating in, that can start to open our eyes to the opportunities. And the opportunities are new and they're different. And just because someone hasn't done them before, it's probably because the opportunity didn't exist. But it's hard
Yeah.
to overstate how much that change is happening and how no one quite knows what to do with it yet.
100%. I think you're so right. I mean, I think, I was just thinking about one of my coworkers used to talk about like as of, and she would list the date and the time. This is what it is, right? And so I think it's important to acknowledge that we're in the United States, we are seeing so many changes in healthcare right now. so many changes in terms of payment for healthcare services, especially what is covered, what's not covered. And so contextualizing or putting some brackets around our conversation of like, as of 12:31 p.m. on April the 21st, 2026, right? This is sort of the state of our understanding. But I think an important part of this is being able to be responsive, being able to be adaptable and flexible as things are constantly in flux is going to be a
Mhm.
part of that billing piece as well.
Yeah. And to recognize that entities are looking for solutions like OT. And I'm
Absolutely.
just like, they're being pitched like digital health solutions that we don't know if they work. And they are like being aggressively pitched those. And we're like, we know OT works, or we have such a bigger evidence base. Like you
100%.
should not hesitate pitching your services as an
That
OT. You should have total confidence there.
Yeah, that it works, but that it's also cost effective. I think that's the big thing that we're seeing an emphasis on right now is people are very interested in how do we save money, right? Again,
Mhm.
going back to healthcare as a business. So again, OT can be a part of that answer, right? And we have the research that shows, right? I was just talking earlier about the optimal program in Ireland that has demonstrated that not only is OT effective, but OT is cost effective in a primary care setting, right? So, how do we leverage these things, right? How do we emphasize that if you invest in OT, we will save you money, right? And we will help to drive down these costs. I think that has to be a crucial part of this conversation and some of the advocacy efforts.
Hmm. I could talk about this part all day, but I want to move on to our favorite part, which is just thinking about assessment and treatment. And I wanted to start with just like your overall advice for this idea of stepping into primary care. That means, or it makes me feel a little worried because that means primary care to me means I'm seeing a ton of different things, potentially at like all different stages. And it feels very broad and pretty overwhelming. Like, what's your advice for going to this potentially broad scope where we don't know what's going to be thrown at us, more so
Yeah.
than in other settings?
Yeah, I think it's such a good question because I see almost exactly that, right? Where a lot of times, and I will throw myself under the bus here, right? Is like when I started getting involved in primary care, my gut instinct was like, I can help you with everything, right? Send me all of your patients for all of the things, right? Because when we're thinking about a lot of times the concept again of like primary care or primary health care is very much like across the lifespan, across all conditions, right? So I was like, great, I can do all of these things and practice to, the top of my license, right? And I think yes, but I think also the problem with this approach, at least for me, is I got burned out very quickly and I think also providers who were wanting to send people to OT got very overwhelmed with like, wait, I can send you every single patient, but how does that make sense? I don't understand. And so what I found to actually be more effective to start is to do a full needs assessment, right? Of like who are maybe like a couple of key providers that you're going to work with. Choose low hanging fruit here, right? The providers who are most interested in partnering. You don't want to spend a lot of time on people who are going to be very resistant to your efforts, but try to find people who are on board with like interprofessional care or exploring some new models of care or service delivery and are willing to partner on something like this, right? And then think about what kinds of patients are they working with, right? What kinds of clients and individuals are they serving? What are the needs that they seem to have, right? And do your needs assessment here to understand that. Do they have a lot of children, right? Is it more older adults, right? What are the diagnoses that are commonly coming up? What are the areas that maybe you can, as an OT, right, come in with our distinct value and expertise and really maximize and address, right? Our primary care providers can address things like health behavior change and things like that. But are they experts on like habit formation and building routines and how to do these things sustainably, right? So this is where OT can really come in, right? So do that assessment, understand where you're most likely to have the highest impact, right? And focus on those areas. That's always my idea or my advice when people are getting started in primary care, right? Is start low but grow with time, right? Think about those high impact areas, make sure that you demonstrate that impact, right? And then expand the services because if you start with too much too fast, you get overwhelmed and burn out, the providers get overwhelmed and confused, and it's just not as sustainable. So that would probably be my main piece of advice for getting started.
I can totally relate to meeting with primary care providers and like kind of teasing out their pain points. And if you land on a couple of those, I remember mine was like falls, driving, and one other thing. And I just like got in their mind for those couple things. And then I got all kinds of referrals outside of that, but it started with anchoring into three. The other thing I was thinking about as I was talking to is I think as OTs, we don't appreciate the level of data that our healthcare organizations have.
Mm,
Like we just don't see it, but like they know which patient types are the most expensive for them and that they're maybe losing money on. So if you can not only talk to the primary care provider, but get to like that next level of person who has that data to be like, is the facility or entity what are they concerned about? Is it chronic pain? Is it falls? And align that, or it goes back to putting on the business hat and being like, as a business, what
mhm.
is this business most worried about? Where do they see their organization losing money? And try to position yourself as the fix to that. Would you
A
agree
hundred
with that data
Yes.
level? Yeah.
I absolutely would, right? And so I think that's where, for example, attending some of those like quality outcome meetings is really important to understand, right? Like, what are the areas that this department or this larger institution is really struggling with? And how can I make sure that I emphasize that I can have an impact in these areas or in this area, right? And so to be strategic about that, right? And to know too that like, yes, maybe, the area that I'm starting with is more geriatrics and falls and, things like that. But then I also know that I might also incorporate elements that go beyond that. And so it'll start to grow, right? Because then organically, I will also be addressing things like sleep, right? Because sleep and falls risks. And, then I'll also be addressing things like stress or mental health conditions, right? So, knowing that even by choosing a couple of key areas, right, you will still also be addressing other areas as well, right? I think there was the episode you had with Allison Stover, you were talking about the different levels of prevention, right? And so I
Mhm.
really appreciated this idea that, like, a lot of times as OTs, we might be primarily working in tertiary, right, at that tertiary level, but still incorporating through our work, right? It's very much blended into more of that secondary level, right, as well. So to understand that some of those things will organically happen and then start to grow or help the providers to understand the growth of your scope as it continues to progress and as that relationship develops with time. But I think it does require some patience and some grace, right? I don't think it's realistic to be like, here are all the things that I can do as an OT and check all that apply and send me all of your patients. Like I said, need to shift our mindset a little bit, right? And remember, it's a marathon, not a sprint. So to grow that will take some time, will take some patience. But to make sure that you're being strategic about it is always really key.
Hmm. We've talked about just how this world is a little more nebulous than our other settings, and it takes putting on our business hat. It takes like understanding the specific setting more, and billing might look different. But I would love to just linger for a little bit on what actual assessment and treatment looks like. I've already gotten the question in the comment, like, what do we actually do in these settings? I know this is a broad area, but I would just love to hear some of the specific assessments and treatments that you gravitated towards in your work. I think that will help demystify what this actually looks like for people.
Totally. Yes. And one of the most common questions that I get is like, what does OT actually look like in primary care? And I always chuckle a little bit because it's not like I'm doing some kind of special OT, right? I think having to remember that like OT is OT and I am an OT regardless of where I go and what I'm doing and who I'm working with. I'm always going back to my cores of occupation, right? Now, what I do, yes, will change, and how I do it will change, right? And so, like I said, depending on the model of care, if I am doing more brief interventions, then in a primary care context, then it's going to look very different than like a traditional, hour long evaluation type of thing, right? And I'm going to be very targeted. I'm going to have a max of 15 minutes to work with a client and to intervene on a specific area, but I'm still being an OT in that moment, right? And I'm still very much using my OT skills and my OT assessments. So, just as an example, if I was working in my geriatric clinic, I would most commonly use like a CATS or a Lawton for a quick ADL and IADL screen. If I have time and I know there's some cognitive concerns, then maybe I would be able to do a functional cognitive assessment like the EADL, and I brought my equipment with me and I can do that. That's wonderful. Always love doing functional cognition whenever I can. And then I would also almost always do a COPM. A lot of times I would use that. I think it's just one of my favorite go-tos to set goals with my clients, to check in on progress. And I think that also an important thing to acknowledge is like, what did I have access at my workplace? And I had access to the COPM at my workplace. So for my doctoral residents who didn't have access to the COPM at their workplaces, we would have to sort of zoom out and think about what's available for you, right? And be thinking about that and, find other solutions to find assessments that they would be able to use. I think also some other common things that I would be addressing or working on in primary care would be sleep. I'm trained in CBTI, so I was almost always, and I think it's one of those things that it's like sleep comes up with everybody at some point in their life, right? So it's one of those areas that I was so commonly addressing. I think sleep, stress is a very common one. Pain is common as well. But then also, I'm a certified aging in place specialist. So, a lot of times, especially in our geriatric clinic, one of my primary roles was like I was going out and I was doing the home evaluations, which, as you can imagine, I'm from Los Angeles. So, it can be quite a spectrum, right? Hollywood mansions to more temporary dwellings or unhoused individuals. And so that would be largely my role is like, going into the home and evaluating the home space, bringing that information back to the primary care team, making recommendations, and then working with the team on how to follow up with anything that needed to be followed up on there. So, but if I were working in pediatrics, right, like then obviously this would shift. It just so happened that the context that I primarily work in is mostly with adults and older adults. So the question about like, what does it look like and what do you do? Again, because it's so large, it's almost like saying like, what does an OT do in a hospital? Well, are you talking about a hospital for adults or pediatrics? And what are the different kinds of things that need to be considered about those hospitals? So I hope it helps to give a little bit of an example of like, I would go in, there are many different kinds of models. It would just depend on the day and what kind of model that I'm functioning in, right? But always going back to my skills as an OT. If I am more co-located, then I'm going in with the physician sometimes. Sometimes they go in first without me and I'm doing more brief interventions. If somebody is, just coming to see me in a primary care context, then we have a little bit more time and flexibility. So I get to spend more time with them. But again, I'm sort of following my core OT processes at all times. So I know, again, it's one of those things I don't mean to be deliberately vague, but just because it is so big and there is so much, right? It's, something that really just depends on where you are and what you're doing, but it can look lots of different ways. And hopefully that helps to give a couple of examples of what it could look like, but obviously not all inclusive.
Yeah, I love the summary of just like you're doing OT, like all these things that you're saying. I'm like, these are what
Always.
we do in other settings. I was thinking of my ideal, this is always my like ideal work setting where I'm like, I would love to do the lifestyle medicine short form on like
Ooh,
every single patient where I get like sleep, exercise,
yep.
just daily habit information, and then be able to do like condition specific assessments like we're used to. And uh, I think that'd be really fun to do in primary care, but that also looks like what we do in other settings. Someone
100%.
wanted to know what setting you would compare it to. I know you haven't worked in many other settings, but they were like, this just sounds like acute care. Is there a setting that you would compare primary care to?
Hmm. I would probably say, I mean, a lot of the work is more like community outpatient is
Yeah.
where I would see like maybe the most close comparison. But, and again, that a lot of that has to do with like what is primary care, what is primary health care. We are talking about, addressing sort of health for all, right? Community based, more population health type of things. So I guess that would be probably the closest comparison I could make it to, right? But a little bit more emphasis on like that secondary prevention level, right? So the complexity level is a little bit lower than you would probably see in a hospital setting, right? Somebody's not usually coming to me, I'm not seeing them right after they've had a surgery, right? Or things like that. And hopefully we do have an opportunity to take more of like a prevention approach or to some of the things that we're talking about. But sometimes we are addressing, and again, this does sort of go back to like what is the context of where you're working. I even though I was working in primary care, I was working in primary care where our system has one of the highest acuity indexes in the country of all academic medical systems. So like the people we were seeing in our hospital were also being seen in primary care and they were very medically complex, right? So again, it just really depends on where you are, what the setting is that you're working in, what the needs of your population are. It's always going to look a little bit different in that way. So I say less complexity, but I don't know. Is it really less complex? I'm not sure that it really is. Because they got pretty complex sometimes, but definitely, certainly not at the level of like somebody's not coming in with like lines and they're having, they're immediately post surgery or things like that. So it is, I guess, lower acuity in that way, but
Mhm.
still lots of complexity in primary care. And I think that also goes to like,
Mhm.
w- what do you like? How do you function in primary care? A lot of people talk about this concept of OT as a generalist in primary care, right? Seeing anything and everything. But I think a lot of us have shifted towards this term of a versatilist, right? Using both breadth and depth of expertise is
Mhm.
necessary, right? Knowing that I can go from one room and be working with, a young child who is having some developmental concerns, their parents are expressing into the next room. I've got somebody who's dealing with depression and mental health concerns. And then I might go into the last room and I'm dealing with a 94-year-old who's fallen, right? So it's a lot, right? And so using that breadth and that depth, both in terms of diagnoses, ages, populations that I might be working with. So it does require a lot of versatility. And I think that can be challenging. But I think for people who really enjoy that sort of challenge, this is going to be a great place for you or enjoy working in a lot of different areas. This might be a great place to see you go into.
Mhm. On one hand, I'm like, this is not earth shattering at all. It's like we're taking what OTs are doing all across the country, lots of times in hospitals in more acute settings, and we're shifting these services just a little further up in the patient journey. So hopefully we have this earlier touch point. In the ideal world, we prevent them going to that hospital, but we're probably doing basically some of the same interventions. We're just doing them earlier to prevent things from getting worse. So on one hand, you're like, that's not earth shattering. But on the other hand, I'm like, the consequences of not doing this feel high. Like if we just stay in this like waiting for something to go wrong mode, like that is feeling more and more like a past era of healthcare. And we are in a new era. Can you just speak to the consequences maybe of not doing this? Like this feels important to me. what are we going to miss if we don't start seeing patients earlier in this primary health setting?
Yeah, I think it's such a great point that you make, Sarah, right? Of like, what happens if we don't do this work and we continue to exist in the system where it's like we don't get people until they are much further along in the disease process, things have escalated, right? And I think the thing that I really think about is cost. Cost is the consequence. And I mean that not just in terms of the cost to the business of healthcare, right? It is more costly to have somebody, right, develop that condition and now it needs to be managed or it needs surgery and lots of expensive care is now associated with it. But I think also cost to the individual, cost to their family, right? This idea, understanding that as someone's health deteriorates, the distress it brings them to have these more acute conditions, right? The financial cost that is on the individual and their families, right? As well as the mental and emotional cost of having to live with these conditions, I think cannot be stressed enough. And then I also think about the cost to our colleagues of not having OT involved in primary care. And I'm referring here to the Quadruple Aim, which is most people are familiar with the Triple Aim, but the Quadruple Aim adds this level of improving the quality for primary care providers or for providers in our system, right? As an aim of healthcare, that we should be caring about the people who are in this workforce. And I think that if you look at like where burnout is happening, right, over many, many years to different specialists in the United States, pretty consistently you are seeing that among the most burned out providers are family medicine providers, right? Emergency department is usually highest, but family medicine is usually right up there. And like, if not the second, third, fourth, or fifth, one of those with the highest reported burnout rates in the country. And I think this is not surprising, right? We're dealing with programs are being cut. Productivity demands are really high. Patients aren't able to come into their appointments and access services due to fear of violence, arrest, deportation. And this brings a lot of weight to the providers in our systems. I really reject this idea of like OT or anybody as a physician extender. I think that's very kind of
Hmm.
pedantic and pejorative or whatever the word is that I'm trying to think of right now that's accurately conveying how I feel about it. But I think that OT has a really pivotal role here nevertheless, right? This idea of how can we improve the triple aim? I think we are seeing that healthcare and our populations, the needs are so complex, right? As our lives are all changing and our communities and our populations are needing services that you must have a team to meet all of these needs, especially as we are dealing with in the United States, lots of changes to our healthcare landscape. And it's unreasonable to expect the primary care physician or indeed any sort of medical provider, any one person to do all of this work. And so I think there is a large cost that we risk by not becoming a member or becoming better integrated into primary care and primary healthcare communities. Like I said, just to summarize, I think that cost is to the financial cost to our healthcare business. I think it's cost to individuals, their families, right? The mental and emotional distress in addition to financial. And then I think also to our team members, to our colleagues, right, as well. So I would say there's a lot of cost there.
I'm just like so convinced we need to do this. I only want to spend like 2 minutes on this topic, but I just want to touch on advocacy. On OT
Yes.
Potential, we have a lot of advocacy resources for people. We wrote to Medicare this spring. We'll write to them again when the proposed rule comes out. Two of the things that we're focused on is like a new recognition on advanced primary care teams, which would look like being able to have a couple more codes that like care coordination codes to match more what primary care has, to be recognized members of these advanced primary care teams. And then there's some other like really specific issues, like we want to be able to bill OT at federally qualified health centers. So there's like some very specific issues that we're going after. Is there anything else you want to add to like what advocacy feels
Mm.
important at this moment to move us in this direction?
I think those are all great things. The only other thing that I would mention or perhaps frame around this idea of advocacy is I use this metaphor a lot of times in the classroom with my students of like, is it a capital letter or a lowercase letter? Because both are equally important. And it just depends on who you are as a person and where you feel inclined. And by that, I mean, sometimes I talk about like assessment with a capital A. These are your formal assessments, right? And they're standardized. But then there's assessment with a lowercase a. And this
Mm,
is you using your clinical judgment and your observation and your clinical reasoning skills, right, to assess the client. And both are equally important and have a place. And I think about that with advocacy too, right? There's advocacy with a capital A and there's advocacy with a lowercase a. And so, this idea of advocacy with a capital A, this is you, right? Maybe writing letters and, meeting with people and, trying to advance the work in primary care on a more national level or international level, right? And publish about it. And that's wonderful and great. But then I think there's also an important need for advocacy with a lowercase a here as well. This idea of like showing up and being a great OT and doing a great job with your patients and building those relationships with providers and being like, hey, maybe I'm not the one who's interested in doing this work, but I met someone and I can advocate for OT or just mention OT in that conversation of like, hey, I think an OT would be really great with where you're working. And maybe you need to explore that as an option because that's actually how we got started at USC in primary care was a happenstance conversation with a physician where it's like, oh,
mm.
all of the needs that you're expressing to me, I think OT would be really good for that, right? So I think not to undervalue those what feels like small, but are equally important opportunities for advocacy. So I think most of us are a mix of both, but if you are just feeling one versus the other, that's okay too. So that would be my recommendation there.
Hmm. I love that because it feels so achievable for all of
I
us
think it's
wherever we're at. You can
yeah,
choose one of those levels of advocacy.
it's what it needs to be. It needs to be achievable, right?
Mhm.
It can't always be this big, insurmountable thing that is only for a few people, right? I think we need to be more inclusive in how we're talking about advocacy and any of these things, right, as well.
Yeah, this is such a big change. It really takes all of us. In our final 2 minutes, I would just love to hear the thought you want to leave us on. We've like covered the global stage, the details, advocacy. What's the final takeaway that you want people to have top of mind as they walk away from this conversation?
Hmm. Um, I hope just feeling really energized and excited about our potential in primary care and primary healthcare. I think that's got to be it, right? I acknowledge there are lots of challenges that are out there. There's work that still needs to be done. But I think even if you're not the one doing the work, like I said, it can be a capital A or a lowercase a. And so showing up and just recognizing that no matter how seemingly small your impact can make a big difference. And I think that would be where I would hope people would leave with this.
Mm. And Ashley, I just so appreciate your story that it's just such a uh, clearly shows us that there is a need out there and you can build a career from it. And even in your case where you weren't even looking for it, like the needs are there and we need to be looking around for them. And the need is very great in this area. And I hope more and more OTs can build careers in this setting like you have. I just so appreciate you, Ashley, the work that you've done, being a pioneer, a true pioneer in this area, and then taking the time to share with us today. Thank you so much for this conversation and your time today.
It's been my honor. What a pleasure to be invited. I'm so humbled and appreciate this. So thank you for that.
Thank you for joining us on the OT Potential Podcast. To earn 1 hour of AOTA approved continuing education for your time today, you will need to sign in or sign up at otpotential.com. Once you're in the OT Potential Club, you will find a 5-question post-course quiz connected to this episode. When you pass the quiz with a score of 75% or higher, you will be able to download a PDF certificate that certifies your completion of this course. Okay, I want to thank you for joining us today, and we'll see you next time.